Please welcome to stage our speakers and session chair, Danny Mortimer, Chief Executive of NHS Employers, to discuss joining up our workforce plans to benefit patients and deliver more integrated care.
Good afternoon, ladies and gentlemen. Thank you so much for delaying your lunch or having had such a large breakfast on the train here that you could come join us for this conversation about workforce. My name's Danny Mortimer. I'm the Chief Exec of NHS Employers and the Deputy Chief Exec of the NHS Confederation, who organised this event with our colleagues at NHS England. I'll tell you a little bit about the plan for the next 58 minutes or so, and introduce the panel to you in a moment. But just a little bit of housekeeping and background. This is designed to be a session that allows some questions and reflections from the audience. You can do that through Slido. I've got a script that I have to read you. Please use the Slido function on the ConfedExpo app or the QR code to submit your questions at any time during the session. We'll obviously do our best to get through as many as we can. And we'll also do it the kind of old-fashioned roving mic, waving at me kind of way as well. And what I will be doing is asking a deliberately quite diverse panel. So Navina Evans, who's the Chief Workforce Training and Education Officer at NHS England, Honor Smith, who's the Chief Exec of Skills for Care, and Aruna Garcia, who's got a number of jobs but is the Chair of the Primary Care Network at the NHS Confederation, to offer some reflections from their vantage point in terms of where we find ourselves with the workforce now. 12 months ago, when I think we met in this room, the long-term workforce plan for the NHS in England was in prospect. It was a couple of weeks away. When we met, we were also in the middle of industrial action by our medical workforce, or sections of our medical workforce in the statutory sector. Some things are the same. We've got industrial action in England, and I know in Northern Ireland as well, from doctors in training. But we have in England a long-term workforce plan for the NHS that Navina and her colleagues negotiated and won some battles with those in government to make sure that we could get out the door. Now, Navina and I in particular have to be fairly careful in this pre-election period, as do our organisations, about some of the things we can comment on. Come back next year, and who knows what we might be able to say and talk about. But we have to exercise some care. But I think there's a couple of things that I would say from my perspective and the perspective of those I represent, who are the statutory employers in the NHS in England. I think the first is there's a remarkable degree of consensus around the messages that are in the long-term workforce plan. A remarkable degree of consensus about the need to invest in education and supply in the NHS. There's a remarkable degree of political and policy consensus about the need for the NHS to do its part in terms of retaining people and improving the experience of our teams and our colleagues who care for our communities. And there is consensus and some debate about some of the reform aspects that are in the plan, some of the things that are perhaps most challenging for us. One of the realities that our colleagues at NHS England have had to deal with in terms of developing the long-term workforce plan, and this isn't a party political point, is that politicians of all colours, combination of ties that they wear, tend to think of NHS funding in boxes. So there's a box which is education, and the long-term workforce plan has won some significant investment about which there is consensus in education. There's then a separate box, or actually a multitude of boxes, which are around revenue, which are around the budgets that so many of you are charged with spending on behalf of your communities. That's a separate box. Politicians think about that, again, wherever they come from, at a separate time. Capital is yet another box. Social care is a different set of boxes, trickier boxes. The connections that you all see, that you all experience in your workplaces and in your teams, aren't necessarily organised in that way, and are difficult to organise in that way in a pretty challenging context for investment in public services overall. So the challenge that we are facing, that many of you in the room are facing around implementing the long-term workforce plan for the NHS in England, is compounded. Navina's job, our job collectively, is compounded by the separation of some of those things. Who knows what the election will bring? You will have personal views. Many of your organisations may have positions on that as well. It's not for us to speculate on that necessarily. But there are some things, and there are some deficits in some of those boxes that I think we all recognise that over the fullness of time will need addressing to be able to realise the ambitions that are in the NHS's plan. And as I hope we'll get a chance to come on and talk with Honor about, I think we in the NHS have been clear that it's not our job to make a plan for social care. In fact, we're not the people to make a plan for social care in terms of their workforce or indeed the transformation of their services for the longer term. But we absolutely recognise that it's in the interests of our communities for there to be an equivalent attention paid to social care and to the social care workforce. And as I think Honor will get a chance to come on and talk about, Skills for Care have stepped into that conversation and are convening colleagues from across social care, as well as colleagues from the health service and other public services, to talk about the aspirations in equivalent terms for the social care workforce in England. I hope that all makes sense. Colleagues are going to say a few words, as I said, just to kind of get the ball rolling. Chances for questions, reflections via Slido, which will pop up magically on my screen here, and we'll also hopefully have a chance for kind of roving mic-based discussions as well. I hope that all makes sense as a plan, and thanks again for coming to join us. I'm going to ask Navina to kick us off in a moment. I'm then going to come to Honor for her reflections, and then finish up with Aruna, and then we'll take it from there in terms of the conversation. Navina.
Thank you. Thank you very much, Danny. So I'm going to just make three high-level points to kick things off. First off, thank you. It's nearly a year, 1 year anniversary of the publication of the plan, long-term workforce plan, which I'm sure everybody in this room has read at least once.
Mm-hmm. Even twice.
Even twice. And actually, it was an ambitious plan, it's a really challenging plan. And where we focused this year has been on delivery. And there are a number of areas that, it's train, retain, reform. And those are the big ticket items. And getting into the detail of how we do that. And we can talk a little bit more about that. I think the space of reform has been quite challenging, as you would expect it would be. And it's really good to hear lots of different voices coming together to grapple with all the issues around the different parts of reform that need to happen in how we train, how we learn, how we work, and how we look after our people. Which brings me to retention, which is the piece of work that has really been going full swing, carrying on from what's happened before. And it's really great to see at the point of care where in the real world, where people are making real efforts to deliver on the people promise, specific interventions to support our people, and it's showing real impact in terms of keeping our staff, in terms of keeping people happy, and then outcomes for the work that they do and the people they serve. There's still too much variation across the country, and we need to tackle that, but there's a lot of learning to spread and learn from. So that's a hopeful thing. The third thing I want to say is, when you start to do this work, you start to understand how important the relationship with social care is. And we did say when we published the plan that this could not sit in isolation. So that partnership we see happening in practice, in the real world, if you like, great interventions of how we are sharing, learning, ways of working, collaboration with our social care partners. I think those of us at the centre will be playing catch-up, which is quite good in a way, learning from that. But we did work together when we developed the Framework 15, which was a framework for long-term workforce planning. So I think that partnership, which happens at the point of delivery, is something we should build on. And finally, I think Amanda mentioned it in her speech this morning, the fact that we are in a good place to really rethink, reimagine how we can bring primary care to be the sort of centre, and by that, in prevention, in creating health, rather than us going further down the line where we are looking at poor health. I could go on, but I'll stop there.
Fantastic. Thanks so much, Navina. So some things there about the plan, about the challenges of implementing it, some of the contentious areas about reform, some of the real positives about retention as well, and some things we need to do going forward in a couple of the service areas that Honor and Aruna represent in particular. Ona, from your point of view.
Over to me. Really pleased to be here, not least because I woke up at 3 o'clock this morning after having a nightmare that I'd slept through the whole session and was still in my hotel room. So even the fact that I'm here means I feel like I'm kind of winning in life just by being here. So as I think Danny and Navina both said, this time last year when we were doing this session, we were talking about how do we make the kind of one workforce ambition a reality in adult social care. And I said, I think we need a similar workforce plan in adult social care that we're just about to launch in health. And so Skills for Care kind of moved into that space and said, well, let's just do one. Let's convene the conversations, get the right people around the table. And, well, why Skills for Care? So for people that don't know us, we are the workforce development and planning body for adult social care. We've got a big data set, about 650,000 individual records of people working in social care, which gives us a really good sense of who people are, where they are, when they leave, why they leave, and the engagement that we're able to have in the sector, because we sit across the whole sector, all parts of the workforce, regulated, unregulated, and so we felt like we were in the space where we could convene the right types of conversations. And I wanted to make that point because this isn't our strategy; it's a whole sector strategy. Our role was convening, and obviously there's parts of it that we will feel like we own. We've been thinking quite a lot about what's the case for change. Everybody is saying in every single sector there's a real need here for change. So why social care? And some of that is the data is really clear. So we are all living longer. That's wonderful, but we're not living healthier, and the demographic growth alone will mean that we're going to need in social care about an extra 440,000 people by 2035, and that's just a projection that assumes that we make no choices, and obviously we've got a lot of choices that we can make, but you add that to the 150,000 vacancies that we have in social care, and the fact that that kind of vacancy rate relative to the population is growing. It used to be about twice the national vacancy rate, and it's growing. And we've got a leaky bucket. So we recruit about 420,000 people a year, and we lose about 390,000. They don't all leave the sector, but that churn is significant. So there's an opportunity for us to do something, I think, in social care that starts to plan for now and starts to plan for the future. And it's not just the shape and the change in care. It's also our expectations of work are changing, and we know that the kind of younger people coming up expect different things, and our expectations of education are changing. And so when we're doing the workforce strategy, one of the things that we're reflecting on is we need to transform adult social care. We really need to be putting our attention on prevention, personalisation, technology. Social care is often at the end of field prevention. So if we don't do prevention well, that 440,000 additional posts, we're going to need even more than that. And there's very little that social care can do to pull that lever. But if we don't pull it, we will see it and feel it in social care. And so we're going to need to transform social care, and we're going to need to think about the workforce. So that's kind of what the strategy is aiming to do, looking at the different levers that we have in social care, how we pull the right lever at the right time. Where is this a commissioning lever? Where is it regulation? Where is it practice? And how do we build on the brilliant things that are happening already, which Navina talked about? And that is going to need really concerted, joined up effort, because we have some choices to make. We have probably two quick levers in social care in terms of workforce capacity, and that's pay and international recruitment. But we've got our longer term, deeper levers, which are about the kind of structure of the sector, but we need to start that now because 2035 will be with us in the blink of an eye. So the workforce strategy will be published in about a month, 18th of July, and there will be a focus on the stuff that you'd expect, a kind of what the quality of roles, so pay, terms and conditions, a real focus on retention. We've got to be keeping the people that we have with the skills and the values that we need. Career development will be a focus, and the kind of small but mighty part of the workforce. So the social workers, occupational therapists, nurses, registered managers. That's kind of 5% of the workforce that are so core. And then a real focus on people's experience in work, and we can talk, I'm sure, a little bit about that. So inclusion, well-being, leadership is so important. And I just want to make one point, because I think I've gone way over 3 minutes, but the content in the strategy is going to be really, really important, but it won't be right, because some people will want more of this, some people will want less of this. And we've kind of committed to aligning with the NHS long-term plan as much as possible, aligning the time scale so that over time they become more and more useful. So as we refresh, we'll keep changing. But there's also a point that I want us not to lose, which is about the process of the strategy. The process in itself is really useful, because I feel like we need to move to a space where a workforce strategy for adult social care isn't something that's voluntary, that it's something that we always have, and that we're kind of able to shift that paradigm, that we have an expectation that we'll have a workforce strategy that is implemented, monitored, refreshed, and is used to join together the different levers in social care to move us forward.
Terrific. Thanks, Honor. Huge amount there. Yeah. Perhaps come back to the question about retention in a minute. Both you and Navina have mentioned that, and I know that's a big issue in primary care too, but Aruna.
So thank you, thanks both of you. Gosh, coming after that is going to be difficult, but I think there are points that are pertinent to primary care. So we've been feeling, haven't we, in general practice, certainly, even before COVID, that we were losing our GPs and we were losing our GP numbers. Made worse by COVID, so retention is a really big issue, with a 3% attrition rate year on year, placing huge pressures on the care and quality of care that we can deliver to our patients, and of course the well-being of the GPs that are left looking after a greater proportion of them. So we really welcomed the long-term workforce plan. I think it's great that it's a 15-year strategy, so we've got that really sort of long-term look which incorporates education and training numbers. So that's fantastic, and that focus on primary and community care, and the idea of moving and understanding that need for generalist skills and holism was absolutely vital with some of those demographic changes that Una's talking about, with complexity, with an aging population, and the increase in long-term conditions that's going to come our way. But we are noticing that we're still losing our GPs despite that promise. We are noticing that we have a greater proportion of international medical graduates that we're also losing after training. So there's something about, actually, is there something about why aren't they staying? So there's a retaining issue straight after training, and there's a retaining issue for mid-career GPs and career progression that we probably need to think about. But having said that, I know, Navina, you mentioned that this is an iterative workforce plan that's meant to be agile and responsive, so I welcome that responsiveness within that plan with regards to the current state of affairs with general practice retention. But on a lighter note, I think that there is a success story sitting in general practice. We have gone, the last 5 years for primary care networks, have seen in the system the single biggest transformation of workforce in the community that's been a little bit silent, actually. But we have to remember that in general practice, we've introduced 30,000 new roles across our PCNs and across our practices, and some very brand new roles. So we've brought in our clinical, our allied health professionals, so our pharmacists, our paramedics, audiologists in some situations, and and physiotherapists. So we are increasing the breadth of expertise in that community shift, so increasing our capabilities. And they've been hugely successful in seeing that demand that we are facing in primary care. So we've seen a productivity increase in primary care despite those GP numbers of about 10 to 40%, depending on what you look at, which is at odds with the rest of the system. Just note that, because so it is possible, we can do this. So it's a success story of not just general practice, but actually our MDT team and how they've worked hard, and they have felt value. I think there have been things that we could do better, and we can go through that a bit later in terms of some of the challenges that we faced. But there is something to note about, so I should say that those ARRS roles weren't just about clinical services. We actually shifted to that prevention model. We went and captured the opportunity for moving from illness to wellness. So we have loads of our PCNs that have employed health and well-being coaches successfully with lifestyle interventions, reversing type 2 diabetes, for example. We've got people that have mental health, occupational therapists that have supported some of that mental health burden, etc. So when you get local leaders to lead and flex to their communities, I have to say you can make magic happen with some of the case studies that I've seen. And just finally, we need the admin, the infrastructure. So something about care navigation that we've been able to bring into the ARRS roles, something about care coordinators, and of course our GP assistants. So really trying to help release the burden of it. But can you see the scope of what I've just described? So is it any surprise that we've sort of come into a place where we thought, oh, we could have done this a little better with supervision. We could have done this a little better with understanding scope of roles. And I think rather than criticising the ARRS roles, let's celebrate what we've achieved, because it can happen in the NHS. And what we need to do is do that bit of learning that Naveen has talked about. And probably, I think one of the things that's come out for me is the bit about leadership. So primary care is quite unique because it has a universal footprint. It is the connector for all our different partners in the system around a patient. And I say primary care because remember we can't forget our dentists, pharmacists, and optoms in this now, and audiology. So we need to therefore there is something like investment in leadership, and particularly collaborative leadership, establishing cultures to work across organisations. I'll describe later, some of our PCNs have done really well with working in their communities with voluntary care sector, social care, to be able to connect into system, to be able to connect into the working with the local authorities, to work with vaccination programs, etc. So we've really managed to stretch our influence and what we can do. So there are opportunities, and I'd love to have to think about that in terms of what else can we do to move that, to shift that dial to prevention, to wellness, not illness, and also to increase that integrated resource and how we work together, because I think that's probably what is the biggest thing that's come out of it, is how do we get an integrated culture that provides continuity of data, of care pathway and relationship as a team of teams. Thanks.
Brilliant. Thank you so much, Aruna. And again, maybe come back to that question about that final point you've made, about collaboration and about actually how we think maybe a little bit differently about communities. Could I go back to the thing I flagged first, which was the retention piece? And I guess maybe just starting with you, Ona, we're all aware, some media coverage this morning about some of the particular challenges around one of the two levers that you face, around pay and some of the limitations there and some of the attention it may have. But on the retention piece, just in particularly for what will be a more health service-based audience, what are some of the things that are kind of coming out as the kind of key levers, key drivers of retention in social care?
So we attract so many people in social care a year, more than the population of Bristol every year, 390,000 new starters. 420,000 new starters, and we lose 390,000, so a turnover rate of about 30%. I mean, and that's huge. And what that masks is, in some roles, that turnover is even higher. So nurses, for example, 36-37% turnover in nurses. Within the first year, we have about 50% turnover, and we lose our younger people. We lose 1 and 2. So that kind of masks some of the issues. So it's huge, and I don't think it's got enough attention. We know from all of the evidence that there's really 3 things that make a difference in terms of retention. One is the quality of role, and that will mean, well, all the normal things you think about. Pay has an impact, terms and conditions have an impact. So we have a rate of about 23% of our workforce on 0 hours contracts compared to 3% in the general labour market. And within home care, that's 46% of the workforce on a 0 hours contract. And for some people that works, for some people that gives the flexibility, but often it's the business model, and it's the commissioning model, and the lack of certainty. And if someone's on a 0 hours contract, they're much more likely to leave. If you pay more than the statutory pension, people will stay. If you pay more than statutory sick pay, people will stay. So quality of role is really important. Learning and development is really, really important. So if someone has a qualification in social care, they're more likely to stay. If you train someone, they stay. The more you train them, the longer they stay. That's essentially what the evidence tells us. And then the third thing that's really important is organisational culture and leadership. So if your registered manager leaves in social care, your turnover increases. And we have about 16% of our providers have a turnover rate of less than 10%, and that's incredibly low, relatively speaking. And when we ask them, well, what do you do that's different, do you think? They don't talk about pay, actually. What they talk about is we live our values, we say thank you, we give the maximum amount of autonomy that we can in people's roles, and we think about our leadership style. And so that won't be a surprise to anybody here, but when we're thinking about retention, it's kind of there's some quick levers that we can pull, and then there are deeper levers that we need to be working on all of the time, really, and kind of chipping away at.
That's brilliant. And Navina, thank you so much on that. I think there is a lot there that will echo with people in the room, but clearly there are some specific, the scale of the challenge in social care is significant. Navina, you've obviously identified in your remarks that there's been real progress in the NHS in the last couple of years. One of the things that's come through as a question on Slido is a concern about educators in particular, because clearly the delivery of the plan, you know, the scaling that we've got to do in the next 10 years, that's a really crucial part of our workforce that maybe we've paid, as employers, we've paid insufficient attention to. So any thoughts you've got in terms of what you've seen in terms of retention in general in the last couple of years, and anything you can point to in terms of educators in particular?
Sure.
That'd be great.
As I was listening to you, so many synergies and so much sharing that's possible at the point of care, where people are working in partnership. So that's really important. But absolutely, as Ona has described, those interventions are evidence-based. They can be applied systematically and consistently. So I see some of the team here who can talk about the detail of the interventions for retention, which is in the context of delivery of the people promise. But if I just pick 1 or 2 things that I think are measures of success, is a relentless focus on keeping your staff, and you do that by looking after your staff. There are some process and structural things you can do. That it is owned by the highest level of leadership, most senior leadership in the organization, that it matters to them, and that there is a real connection between belonging and outcomes. And we have that in the staff surveys, staff engagements. You can see all of that. So it's putting the effort into that, and it really does pay. So the retention exemplars, the work that's being done across the NHS in England, and actually the retention exemplars now have 2 PCNs in their cohort as well. So there's no reason why you can't use these interventions in primary care or the ambulance sector or share with social care. So in terms of educators, we were very aware when we developed the plan that a massive expansion, which is due next year, will require a reimagining of how we educate and how we train and how we teach. And that's not just in trusts or in primary care, but also in higher education, further education, and also in local authorities. So it's not just more numbers, but it's also how we use our staff differently, how we learn multi-professional, multidisciplinary, blended learning, how we use retire and return, all of those, so many opportunities for expanding the educator workforce. The one key thing is that it's become a high priority in the NHS. People are now thinking about educators as a really important part of their workforce, not something that's sat over there in training in, you know, CPD or something like that.
And there is something there, isn't there, about, because actually the organisations get quite a lot of feedback about the education they help provide. I don't always know, if I reflect back to my time on trust boards, I don't know how regularly we feature that feedback, whether it's from the deanery visits or the GMC survey or from the feedback we get from student experience through universities or anything like that. There's some, and I know there are organisations that are increasingly saying, well, no, the core part of our business, we need to kind of have a conversation with our boards about that.
And just a little shift in mindset. Our students, learners and trainees are part of our workforce now and the future. So we don't think about them, can't think about them separately.
And I guess that there's also that challenge which I know we've talked about before, and we've talked about with those in government and those who may be in government in the future, which is education is one of those areas where there's been a huge amount of so-called discretionary effort, people doing stuff for free. And actually we're well beyond the limits of what's acceptable in terms of that, and we can't expect that from people. So it's encouraging to hear the conversation is happening. There's clearly a lot to do. Aruna, you mentioned towards the end of your remarks the kind of the positivity there is around that kind of wider conversation in communities, that kind of sense of actually assets in communities. My words, not yours. Could you just expand on that a little bit more, and perhaps, Honor, I could come to you as well in terms of your experience of that in your sector?
Absolutely. I think that COVID showed us it, didn't it? More than anything. COVID demonstrated the need for us to think a little bit differently with our communities when we saw the massive, stark differences in people dying from different communities and different pockets of where people live in your area. And the other bit was, of course, people and the vaccination rate. And it forced all of us, and particularly general practice and primary care networks, because they delivered the bulk of the vaccination programme, to think about that differently and how they connected with their communities. And we understood that, of course, that whilst you may have a general way of approaching something, sometimes you need to personalise your approach to those communities because of who they are, the cultural differences of the individual, for example, and personalise it to the individual in terms of their health beliefs. And we mustn't forget those wider determinants of health, and that's partly why I wanted to introduce that before we talk about communities. So with that in mind, and thinking that one of the primary care networks weren't just charged with delivering enhanced access, which people might think, or improving access to primary care, actually it was charged with delivering reduction in health. If you go back to the long-term plan, reduction in health inequalities in the community, thinking about that shift to prevention and thinking about proactive care. And we worked out that actually from there, that we suddenly started to have connectors in our community. We had people that we talked to that hadn't ever connected with general practice in the past before. And what we've noticed is that with our ARRS roles, and the social prescribing link worker in particular has been absolutely vital to put a different perspective on a patient encounter. we've got to remember that health outcomes, 20% of them are related to medical intervention. That's all how important I am, but 80% is related to those social determinants of health and wider things. And it's almost ignore them at your peril, I think, in terms of some of that thinking in those, you know, in the cliff edge that we have in terms of demographics and aging population. So what primary care did, certain primary care networks did was started to use, with their health inequalities work, was started to understand, have a population health approach, and started to understand some of the gaps, for example, in falls, in multiple attendances in A&E, in vaccination rates, for example, in follow-ups, or people that were DNAing, people that had, you know, we do quality and outcomes frameworks, we monitor long-term conditions in general practice. So we've realised it's actually the ones that don't come in that we need to be focusing on, rather than the ones that have, that are engaging with the system. So what, I think we've had some really successful stories of social prescribing link workers helping those very individuals with personalisation and linking them back up into their community. Working on gardens, for example, just that well-being, so just respecting their mental health, not just their physical health. Working on gardens, going on walks, for example, and using community assets, so using what we call a strengths-based approach, so that there are people and voluntary care sector organisations that will be keen to expand their services in the community. It doesn't all have to be us. So we have demonstrated, actually, we've demonstrated it from a cardiovascular disease perspective in terms of prevention and improving uptakes for weight management and improving uptake for physical exercise. We've demonstrated it with our social prescribing link workers and our health and wellbeing coaches, and in terms of reduction of A&E, conveyance to A&E, so 60% reduction in A&E attendances if we targeted that care into that cohort and brought in the community. So 45% of frequent attenders in one PCN went to the social prescriber, and there was a reduction in A&E attendances of about 30%, but 70% reduction in general practice attendances. That's what we're missing. Okay. And I think so. I think there's something about moving from a medical model to a more social model and being courageous and brave. So there is a cultural shift that's involved, which is difficult. I can say it personally, it's difficult as a GP, because that's not quite continuity of care, etc. is something about, I look after my patient, but actually maybe we've grown with primary care networks and understood this is about activating patients and empowering patients and activating communities. So I'm really excited about this space. And I think it isn't just about primary care networks, actually. We need to understand how we bring in the system. How do we bring in trusts to understand this exists, and how do we get them to have that conversation?
And I know there are some, I've visited the acute trust in East Lancashire recently, and I know, again, a lot of what you're describing is what I heard their chief exec and his team describe. Ona, you clearly talked about, you know, the first key part of your strategy when it emerges is how we think differently about social care and about social care provision. Again, I guess a lot of what Aruna's talking about has echoes in what colleagues in social care are discussing.
Yeah. So I was just thinking, as you were speaking, Aruna, that it reminded me of a young, I used to work in a big social care provider, learning disability provider, and we supported a young man who came to the door of A&E, was living under Brighton Pier. He was about 24, and the reason he had ended up there with multiple health conditions was that he had 1 hour a week of social care support, quite a mild learning disability, but needed some support to pay his bills, and that 1 hour a week was cut, and so he had no support. He couldn't work out how to pay his bills. He didn't pay his bills. he got evicted. He ended up living in Brighton, under Brighton Pier. We supported him to both challenge that decision, but also to get a job and to access the assets in his community. And then the last I heard, and this was about 2 years after, he was working in McDonald's. He had a girlfriend. He'd met a girlfriend because he was out in the community. He no longer needed any social care support because actually his girlfriend was really good at paying bills and they lived together. And so that 1 hour a week was preventing something escalating. And once that was taken away, the only place for people sometimes to go is A&E. And that's the only time that we get to see people. So there's something about, for me, in social care, and I feel like I say this every time I'm with you, Navina. You must think that girl only has one thing to say, but I feel like we will know when this has worked, when social care is spoken about as if it's not the problem to be solved, but it's part of the solution. Social care at its best deeply understands people and the people that we are supporting. We don't talk about patients, we talk about people, and we understand their lives, how if someone's behaving in a particular way, we know that's not normal, what's happening there. We know their families. We build a really deep relationship with people at its best, not all the time. But what that means is that when we're thinking about personalisation, when we're thinking about prevention, when we're thinking about well-being, then social care is a kind of equal partner in that conversation and can play a real part in that strengths-based approach. So in my mind, there's almost a strengths-based mindset and a strengths-based approach. And if we see social care as the problem, then we're kind of not getting the mindset, and we won't then get to the approach. So there's a kind of thinking process that we need to go through to kind of recognise that. So even in that final point that you made, Aruna, about the social model, well, that's where social care starts from. We start from the social model, not the clinical model. So we have stuff to teach as well as stuff to learn. So the more that we can get into that conversation and join those together and move our kind of services and our conversations to the doors of people's homes rather than the doors of hospitals, I feel like we'll all be kind of working towards the same aim, and it'll be more impactful.
Brilliant. Thank you so much. And again, as you said, very similar points that you're both making, and it challenges us all. And a big theme of the 2 days is how we can kind of think differently about these things, and also highlight some of the things that are already happening. So the one plug I'll make is that Honour's organisation and mine have been doing some work together in the last couple of years around integrated workforce thinking, integrated workforce action. And on our website, the NHS Employers website and the Skills for Care website, you will see stories, you'll see accounts of where health and social care, health in its various forms, social care in its broadest sense, are working together in your systems, your places, to make some of the changes that Aruna and Ona have touched on. So as Navina said, there's actually, there are 1,000 stars out here, and sometimes we're running to catch up nationally, and we're trying to do our small part in terms of trying to elevate and share some of those stories and some of the learning from it. So integrated workforce thinking, there's a whole series of things that are shared there. Just before I come to the floor for questions, the most upvoted kind of question that's come through on Slido is about attraction. And it's particularly about attracting young people, but if I may edit slightly, I guess, yes, we're in the business in social care and health of competing for young people to come and work for us. But I think one of the really interesting things in the plan, which reflected what employers in the NHS are doing, is we're also in the business of competing for people at later stages of their lives. 50% of apprenticeships in the NHS are undertaken by people over the age of 25. And we tend to think of apprentices as 17-year-olds. So there's something about a both-and approach to how we attract people, but it is becoming more challenging. So perhaps each of you, just any reflections, you've got anything you've seen that, in terms of what good looks like in terms of attracting people at whatever stage of their lives to come and work in our sector. Navina, from your point of view?
So we did quite a lot of work at asking people when we worked on Framework 15 and the long-term workforce plan. And we can no longer rely on our brand. And just that, the sense that people want to work in health and care because it's very rewarding and it's special and all of our own personal reasons. So we have to understand how people want to live, how people want to work, and how people want to learn. And it's changing. And therefore, we, certainly in the NHS, and I know we've talked about this, but also at organisational level, really think about, is our offer as attractive? So things like flexible working, really important. The leaky bucket being turned into a water wheel, and how you make it attractive for people to want to work with and for us.
So it's not glossy TV campaigns. I know my kids don't watch TV anymore, but it's not glossy TV campaigns.
TikTok.
It's or TikTok, or whatever it is the kids are down with now, my face, Facebook, talk. It's actually about our reputation in our communities.
Yeah.
Yeah. Ona, from social care, in terms of attracting people into your sector?
So I find this so exciting because I feel like there's such an opportunity in social care. You know, what we hear from particularly the younger generation is we want purpose and we want flexibility. I mean, there's a lot of things I can't give people in social care and roles, but I can give you purpose and I can give you flexibility. We just also need to make sure that they are good quality roles as well. But we don't talk about that enough in social care. Well, if you just take a step back, what do you hear about social care? Well, you hear, I'll be underpaid and undervalued. Well, no, thank you very much. And in our adverts, we can talk about experience of personal care. I need experience of personal care. Well, who talks like that in real life? You know, everybody here jumped in the shower this morning. Nobody said, I'm going to do some personal care. So we've got to do something about describing the role of social care and the role that you will be doing in a way that's kind of attractive. I was speaking to a young man who is supporting people with learning disabilities, and he said, I get to play football in the park and go to the pub. What's not to love about that as a role? But there's also social care is one of the few roles that there are no barriers to entry, very, very few barriers to entry, and you come into social care, we will train you, don't worry about that, we will train you, we will develop you, and we have so many examples of people. One of my last CEO started as a personal assistant and then ended up running a £200 million social care provider with 7,000 staff. We don't tell that story enough. So this is a workforce where you can support people every day. You don't need to develop. You don't need to go into management. You can specialise in your practice. You can be excellent at what you do, or you can develop. David Bain described the kind of career framework as, we talk about an escalator where you go up and people can get off at this level or go up to this level, but actually it's more like a climbing frame. And that's what we have in social care, the ability to go sideways, to specialise, to develop. And I think that we need to be talking about social care differently, because we've got a moment in time to really attract the 18-year-olds that are coming through now, the scale of which we won't see for the rest of this century.
I'm sold.
I know, I'm going to join.
I'm going to, yeah. Aruna, you, as you described in your remarks, you've drawn in a huge amount of new people to come and work in social care, many from other parts of health, but you also talked about some roles, the link worker role in particular, which obviously are about people entering primary care from all sorts of different backgrounds. What things do you think attracted people to come and work in those kind of new roles that you've described?
Yeah, it's really interesting, isn't it, actually? I think through this journey with primary care networks, I think sometimes when we talk about value, we underestimate just how powerful that reward is of looking after somebody. And it can just be one person. It doesn't have to be targets. It doesn't have to be KPIs. It doesn't have to be health outcomes. It's just making a difference. And that powerful connection is, I think, what draws people into primary care, because we're able, one of the things with the ARRS roles in particular, is we're able to provide relationship continuity. That's what's exciting for a lot of people when they come out of other areas, because they have time to spend with a patient to help them. I think with community link workers, I have to say it was a very, very new role in those early days of year one, and a lot of people were brave, actually. I think we brought people in with a vision who understood some of those difficulties that Una was describing, some of those gaps that existed between medical care and that social model, and wanted to link it up for their communities. So you found people that wanted to make that difference, that were usually coming from voluntary care sector organisations, that wanted to be able to do more with their communities and be able to link directly up with people that needed it from that medical perspective, in terms of identifying those, people that were frail, lonely, older, or people in need, etc. So I think that when we get to, and once you start to socialise that aspect of primary care in the community, the word gets around, because suddenly it's not an us and them, it becomes, actually there's a place where we're together. And that's when we start to bring in, and I think COVID did that, where we started to build trusting relationships with leaders in the community and champions in the community. And I think from those conversations, we then brought out those community link workers. If you think, I don't know how many of you have heard about the Brazilian model. I know a lot of people are talking about it now. But there is an idea out there that we can dig in much deeper into communities, actually. And we can have people that are working across social care and primary care that are actually in the heart of their communities with a certain geography that are knocking on doors. So where you know that a community isn't engaging, or these streets aren't engaging, we've got people, and it is financially beneficial, I'm telling you so, but people go knocking on doors, and we get engagement, we reduce loneliness. Remember, loneliness has a 26% is responsible for poorer health outcomes. Loneliness by itself, never mind, right? My drugs are less than that. So there's something about actually investing in those community champions and those community link workers. They've shown a reduction in general practice appointments, they've shown a reduction in A&E, and more importantly, they've gone to that bit of screening. So screening and detecting hypertension and self-care. So we get a culture change.
Building the links to the communities, that's fantastic. We've probably got time just for a couple of quick questions. We've got one here at the front. Sir, and then there's a lady behind you, so we'll probably have time for a couple. Hi.
Yeah, hi, thanks very much, Danny. John Waters from NHS Professionals. Honor and Navina, you both touched on flexibility. What role do you see, or what opportunity do you see for flexible working and the flexible workforce in enabling integrated care?
Navina? Start with you, and then we'll come to Ona quickly.
So, gosh, huge is the answer. Because I think ultimately we should all be thinking of ourselves as being part of a flexible workforce. And that's not just meaning your flexible hours, but also how you work, where you're deployed, how you're deployed. So, as the models of care change over time, one of the things we expect is to grow a workforce that can be flexible depending on, so their skills are flexible. So new developments, new treatments, new models of care, you don't get stuck because, I only used to work in this model, so I can't possibly. So when we talk flexible, we're not just talking about our working hours, but we're talking about the future is in flexibility. So the opportunities, I think, we probably haven't imagined what the possibilities are yet.
Yeah.
I agree with Navina. Navina always says skills, not just roles, skills, not roles, and that kind of sticks with me, because it's almost, we've got one toolbox. Let's use that toolbox to the kind of best ability that we have, and so being able to match the workforce with people's needs will be really important. And so that flexibility feels like it's really key. We have some examples across systems where they're really leaning into that flexibility. They've got, shared roles where people will be doing home care, and in some of their downtime, they'll be able to provide some support as a healthcare assistant, and so working across those boundaries. The organisational boundaries can get in the way, and we've got to keep going at trying to remove those organisational boundaries, trying to align things like terms and conditions, and because there will be an osmosis between health and social care if we don't do that. But that shouldn't stop us. That should be a reason for us to kind of try these things. And flexibility is so important to the workforce, and it's really important for the people that we support. So we have to be the ones that change the system to make that easier.
Thank you, Anna. We'll get a lady here in the middle with a question, and we've got probably chance for one more here at the front. So we'll take you, please.
Thanks, Danny. So Victoria Beyer, I'm the chair of Age UK Lancashire, so it doesn't surprise me you told me Lancashire was doing great things.
Go Lancashire.
We run one of the largest take-home and settle hospital aftercare services across the whole ICB we're extending. And interestingly, what we found is great partnership comes, as you've all talked about, from grassroots level all the way through to the senior management within structures, and we can really achieve things. The interesting factor for us is the unseen, unheard stress. So we've also, in the last quarter, had 5 dead bodies that we've identified in our staff, and we are paying minimum wage because that's all that we are contracted to pay. So how do we develop resilience within our staff? How do we really engage people to be retained? Because this is a highly stressful, highly emotional job. It doesn't matter where you are within the system, but we could do much better.
And I'll perhaps ask Aruna just to reflect on that, because I think that echoes a number of the things that Aruna's been talking about, and then I'll come to you and we'll wrap up at that point. But Aruna,
I'll make this
please.
quick, yeah. So I think that's a really fantastic point. I think that's one of the challenges, right, to be on the front line, is the resilience, and particularly with some of those very new and very green roles. And this goes back to leadership, doesn't it? And it goes back to that organisational culture and feeling like you can belong and feeling like you've been trained to be supported, and acknowledging some of that stress, and acknowledging what happens when you see a dead body. You know, as a GP trainer, that first sign off that we, as an educator, when your medical student, or your house officer goes and certifies a dead body, it's actually traumatic, isn't it? It's very, very difficult. So I think, first of all, noticing it and being compassionate, being inclusive about what that might mean for that particular person, but making sure that the organisation leadership around it are supporting them, not just with the culture and allowing it, but the support behind it in terms of counselling, etc., particularly with an environment where you're dealing with people at the later end of life, where we know that it may be something that happens, right? It's going to happen.
Yeah. Thank you, Aruna. Thank you for your patience. Hi. Yeah, you're good?
Thank you very much. Just 2 quick questions. What were your experience in trying to retain your more experienced staff?
Yeah.
Because what we have found is that we have quite a lot of new recruits, but not quite the skills, so that's given a deficit. And then in terms of allowing and providing flexibility and the compassionate care, which we all totally agree with, I'm sure, how did you manage that when it comes to juggling the books from a finance point of view to temporarily plug the gaps, probably with locums or extras, to give you that space to actually develop a sufficient number in your workforce to give the true flexibility that would allow you to retain your staff? Thank you.
No, thank you so much. And if I may, I'll take this one in particular and then kind of invite you to say thank you to the panel. I think that point you started with, which is about the experience in our workforce, I think there is a really interesting conversation for us to have, and lots of us are starting to have this, which is absolutely we need to focus on the experience of people who are entering the workplace for the first time and helping them with those experiences. But actually our workplaces are also workplaces for older people too. And there is something about our mindset in terms of attracting and retaining people at later stages in their lives that adds a richness to our experience. It adds a richness to education, as Navina talked about, and it requires us to think, well, flexibility isn't just for someone who's got a small child. It may also be for other reasons in people's lives, and there is something of a reset that I think we're having to go through in the sector. It's such an important point.
Danny, can I say, Ron Kay over there, can you put your hand up?
Hello?
Is the person to go and talk to, because there are specific things that we are doing to keep our more experienced workforce.
Cool. There we go. Connection made, only a row away from each other. Ladies and gentlemen, thank you so much for your attention. And if I could ask you to pass on your thanks to our panel, to Ona, to Navina, and to Aruna. There's a whole set of things that we've talked about. There's clearly a workforce plan that's coming for adult social care in just about a month's time, which I think is hugely important to us in the health service, but obviously even more important to our colleagues in social care. I know there is work to iterate and further develop the long-term workforce plan for the NHS in England that Navina's team are leading, and part of the challenge that has been set for that plan is to draw a lot more on the kind of fantastic things that you're doing in your communities, in your systems. And there's a huge amount for us still to do in our communities and with our communities and in service of our communities, as Aruna's touched on. I'm 34 years into my career in the NHS, and I'm very aware that I'm being challenged constantly now to think very differently than I probably have for most of that time. So thank you to the panel for continuing that conversation, and thank you for your attendance and your interest. I'll let you get away and grab some lunch. Thank you very much.